Hey everyone, it's Adam Farkas. Welcome to another ODwire webinar. And tonight is all about the Optovue Solix. And we've had a great series about Solix over the past year on the website, exploring all of its different functionality, talking about its use in different disease states, both the OCT functionality and the OCT-A functionality. Tonight we're going to be talking about a brand new topography module that just came out. And fortunately, tonight we have two experts to walk us through how it all works, Dr. Nate Lighthizer and Dr. Aubrey Tackett. You obviously know Nate if you've seen past ODwire webinars. You've heard him speak before about Solix, and he's going to continue on tonight to tell you a little bit more about it. And Dr. Tackett is Dr. Lighthizer's colleague at the Northeastern State University, Oklahoma College of Optometry. So they work together, and she's also an expert in Solix. She's been using the device extensively, so she's going to help walk us through all of its functionality tonight as well and show you the new topography module. So with that said, we're doing a little differently tonight. We're not going to actually do it live. We actually did this recording with Drs. Lighthizer and Tackett previously, because, as you'll hear in the presentation, Dr. Tackett has a newborn at home, and for all of you with newborns or remember having newborns, you know that they can be somewhat unpredictable. So we wanted to make sure that we were able to actually get through the presentation uninterrupted, but Nate and Aubrey will be here at the end to answer questions live. So here we go.
All right, good evening, everybody. Hope you are doing well, and welcome to the Introducing Optovue Solix by Visionix. My name is Dr. Nate Lighthizer, and it is my absolute pleasure to share the stage, the virtual stage, with Dr. Aubrey Tackett this evening, one of my former students and residents and now colleague here at NSU Oklahoma College of Optometry. Really looking forward to this next 45 to 50 minutes, where we're going to talk for 35 or 40 minutes on all of the wonderful technology that is in the Solix by Visionix, the OCT angiography, and we're going to unveil some new toys inside this machine tonight that just really makes us such a well-rounded clinician from front of the eye to the back of the eye, anterior segment to posterior segment. So Dr. Tackett, awesome, just so very excited to chat with you tonight and hear about all of your expertise.
Yeah, super excited to be here. This is definitely my favorite piece of equipment we have, so I'm really excited to share with everyone else kind of all the great things it gets to do.
Yep. A little bit about me. Come on, slides. I am, again, a faculty member at the Oklahoma College of Optometry. Hard to believe, been here for 15 years. Pacific University graduate, and did my residency here in Oklahoma in 2009, 2010, and now I serve in a variety of roles, including our dean of the College of Optometry here. Love all things ocular disease, from front of the eye, back of the eye, lasers, injections, dry eye. Dr. Tackett's going to lead us through an area that really is not my forte, which would be contact lenses and anterior segment. I'll offer color commentary in that. But I just love all things ocular disease. You can see my wife and I in the bottom left, and our two wonderful children, Adeline Grace and Camden Luke, who are now 12 and 9. Dr. Tackett.
Yeah, so my About Me page got a lot more fun and cute about a month ago with the addition of our little baby Hayes, who has really kind of shifted our life's focus. My old About Me page had pretty big pictures of dogs and pretty big pictures of my alma mater, NSU OCO, where I completed my cornea contact lens residency. And then whenever I wasn't in the contact lens clinic, spent a lot of time with Dr. Lighthizer in our specialty care clinics, learning a lot about dry eye, laser procedures, lumps and bumps removals, things of that nature. And so we're just really excited about this new addition, and made our dogs a little bit smaller, and they're not too happy about that, but they'll get over it pretty soon, I'm sure.
That's awesome. What a beautiful baby boy that Hayes is. So, all right, what we're going to cover, we're going to talk about the Optovue Solix by Visionix, and this is a machine that Dr. Tackett and I are very, very familiar with. We're really going to emphasize and spend a lot of time on what's new. The Solix has been around for a couple of years now. With OCT and OCT angiography, and it's got beautiful fundus photos built in. But what's new? The topography module, being able to use this in the contact lens world, anterior segment, keratoconus diagnosis, as Dr. Tackett will so eloquently cover here in just a few minutes. And how are we familiar with this? It's hard to believe it's been 5 years since myself and a couple of our colleagues were asked to do some of the FDA trials for the Optovue Solix OCT and OCT angiography. We were one of 5 sites in 2019, pre-COVID, to do the reference database. So one of 5 sites, we got to see over 100 subjects. Again, normals are a reference database, and we collected that data for Optovue in 2019. Fast forward a couple of years into 2021, 2022, we were asked to be the sole site for the R&R study, the reproducibility and repeatability study, to show how does this compare device to device to device, Solix to Solix to Solix, and compare it to the Avante, which is its predecessor. So lots of experience with the Optovue Solix in 2019 and 2021, 2022 through those FDA trials. And then fast forward to earlier this year, Dr. Tackett, along with a couple of her colleagues, they got to do the anterior segment stuff, the topography, tomography module, and that's really what she will be highlighting. Phenomenal device, all of this packaged into one Optovue Solix, now by Visionix. So we're looking forward to covering what's new, that topography module in the anterior segment in just a little bit. But before we get there, why Optovue Solix? Again, as I just mentioned, this thing, full range anterior segment to full range retina to glaucoma to exclusive angioanalytics. When you've got OCT angiography, to be able to have that data, the numbers that analyzes this, looks at this, flow, non-flow, we'll talk about it in just a second. They do a phenomenal job in terms of their angiolytics, exclusively by Optovue and Visionix. We've got the wellness scans, the eye wellness, and again, the new topography protocol, complete comprehensive assessment of the anterior and posterior surfaces of the cornea, distinguishing epithelial cells and stroma. Again, this is a full range device from very front of the eye, top layer of the cornea, the epithelium, to back of the eye and everywhere in between. Awesome, awesome device there. So there's your full range anterior segment. Aubrey, these images just phenomenal. This is your baby, what you just completed in this. Look at these images. I mean, look at the resolution, the angle. I mean, we could use this for peripheral iridotomies and laser clinic to scleral contact lenses. Your thoughts on this image?
This is probably my most run image, I would say, and this has been around on the Solix device, but with some updates that we'll get to talk about here in just a little bit. And it just really, like you're saying, it's such a versatile image. We use it a lot in laser clinic to assess the angle and have a quantitative analysis of what that angle looks like pre and post peripheral iridotomy. And then just the scleral lens image that you can capture on this device is really unmatched and looks really great for clinical care as well.
All right, so again, and even ocular surface, you think about, oh, it's an OCT, we're using this for glaucoma and retina. No, we're also using this for dry eye, epithelial disruption. How's the ocular surface look? Look at the tear meniscus, get an en-face images of the surface. What type of disruption is there? And I cannot emphasize enough the importance of meibography. A picture is worth 1,000 words, and we all know that dry eye is getting younger and younger and younger, and we're on our digital devices from very early in life. And we're seeing more and more meibomian gland dropout. And you may have a relatively asymptomatic patient, or at least they think they're asymptomatic, but yet you take a picture of the meibomian glands and you're seeing extensive meibomian gland dropout, as you see on those images on the right there. This device will do all of that, from retina to nerve to extensive retina to all of this ocular surface stuff as well. So just, again, just a tremendous tools in your toolbox when you have that. Full range retina. You take a look at the full range retina and the depth of this scan and the width of this scan and this 2 millimeter window competition. You just got all of these structures that you can see here, and it just gives you the resolution that is very, very nice that we expect to see. OCT angiography, to be able to build these bigger and bigger and wider images, stitch them together to have a montage, to be able to see capillary dropout, vein occlusions, neovascularization. Again, the Optovue AngioView OCT angiography has been the leader in this space for analytics, image quality, and it's just getting better and better and better there. So it's the only FDA cleared OCT-A metrics. And again, depending on the condition we're looking at, if we are looking at macular degeneration, conversion from dry macular degeneration to wet macular degeneration, we are looking for abnormal flow. We don't want to see flow. That is a likely choroidal neovascular membrane, and you can highlight and measure areas that are abnormal flow, as you can see on the left. So this would be more of your macular degeneration. You come over here, and now we're looking for non-flow areas. This is more diabetes, diabetic retinopathy, vein occlusions. We go back a slide here. I mean, look at this big montage. Look at the top half of this image versus the bottom half of this image, and look at all of the non-flow in that inferior arcade. Again, so non-flow, I'm thinking more diabetes, diabetic retinopathy, vein occlusions, you know, vascular disease where capillaries are dropping out, signs of ischemia, and we now know the literature guides us that these things will likely happen before venous beating and before microaneurysms and before hemorrhages. So can we pick up diabetic retinopathy even sooner? So look for areas of non-flow. Look for FAZ metrics. Being able to measure that foveal avascular zone should usually be somewhere between about 0.15 and 0.25, the size of the foveal avascular zone. And as that FAZ gets bigger and bigger and bigger, as you're seeing that enlarge over time, that is a sign of DR progression, diabetic retinopathy progression, retinal vessel density, going along with that non-flow, even disc vessel density. Looking at this before that we can see changes on the retina. That's the beauty of OCT angiography. And then you combine this all together into the report. And Optovue Visionix now has done such a tremendous job of putting everything together on one report, from your fundus photos. Remember, this Optovue Solix by Visionix not only has OCT and OCT angiography and all the anterior segment stuff, but there is a fundus camera in there as well. So you take pictures, you've got that on the report. This would obviously be an OCT angiography of the macula, and we're getting our different layers: superficial capillary network, deep capillary network. This is the outer retina that should be avascular. This is where choroidal neovascular membranes would show up in macular degeneration if it's converting wet, and then down into the choriocapillaris, which would also show signs of choroidal neovascularization. And you know, you'll notice here that they have a new color scale. It's not just the green and the blue on the thin side and the red on the other side. There's now new reference database colors to help reduce red disease, to help, you know, just because something is in the red doesn't mean that it is abnormal. What does red mean and what does blue mean on the other side? They are a statistical deviation from normal. Doesn't mean that they have pathology, but not all normals fall between 5% and 95%. Most of them do. 90% of normals fall between 5% and 95%, but not all fall in that green range. There are some normals that fall in the red and fall in the blue, and us as doctors, we see red and we think, ooh, that's abnormal. To have you know, something in between yellow and red helps to give us just another layer of data, another layer of interpreting data and analyzing this. So that's our new retina report. Awesome. Gives you your vessel density numbers, as you can see: superficial density, vessel density, deep vent density, and there's our FAZ measurements. Again, I like to look at that area. Is it somewhere between 0.15 and 0.25? The bigger that number gets, the more abnormal it gets. So lots of numbers that we have now. That's more data for us, and data is power. Data is power for us. How have they done this and made this better and better? We've got new advanced glaucoma scans and retina scans as well, but specifically on the glaucoma side. As the resolution gets better and better and better, and they take the new scans in different patterns, better resolution. You know, notice when you do all these radial scans here, it's hard to tell what that picture is, the resolution behind it, but when you take these scans and apply them in a better resolution, quicker, tighter pattern, now again, we got more scans there, and now you can see it's the same picture behind both of them, but you can see much better what's going on with the new advanced scanning pattern versus the way it's done previously. You are less likely to miss something. Did you see those two small little fish down at the bottom in this kind of diagram here on the left side? I missed it the first time, but you can clearly see what's going on the right one. And then, as this gets better and better, and this was part of the R&R study, we want repeatability and we want reproducibility. And we want things to be repeatable and reproducible, machine to machine to machine, scan to scan to scan. It's repeatable and it's reproducible. And Visionix, Optovue, they've done a tremendous job. And notice they've taken this 3 times better than it was before and twice as good as most other OCTs. You're taking the R&R from 2.2 microns down to about 0.7 microns. How have they done that? By, again, just what we talked about before, different scanning, better resolution, different scanning patterns, so we can see everything going on in this scan, as we've already talked about. And there it is blown up there. Our R&R is down to 0.7 microns, down to 0.7 microns. That means when you have change over time in glaucoma, when you have those microns changing by 2, 3, 4 microns, you can now have more confidence that says, you know what, a 2 to 3 micron change, 2 to 4 micron change, that's just not the, it's just repeatability, scan to scan, reproducibility, scan to scan. We now know the R&R is down to less than 1 micron. So when you're seeing 2, 3, 4, 5 microns of change, you now have the confidence as the doctor to say, you know what, I think we are seeing progression on this patient. It's just not scan variability. That's the confidence we want with our scans. Here's your glaucoma report. Aubrey, I know you look at these as well. I just love that everything is here, from fundus photos. You've got your RNFL deviation pattern here. You've got the comparison to a reference database. You've got your ganglion cells, OCT angiography. You've got the tables here to give us the numbers. Your thoughts on this printout? Just nice to have everything together, isn't it?
Yeah, for sure. It's nice to not flip back and forth.
And you can control this. You can control this, like you said, you know what, I want to see the deviation map for the ganglion cells. You can click this on the right side here. You can click this deviation map, and then it will show you what's the deviation from the ganglion cells compared to an age-matched reference database. So one-stop shop for everything here, from photos to OCT to ganglion cell to OCT angiography. And we're still even figuring out how to utilize OCT angiography in glaucoma. We have a pretty good grasp on it in retina, AMD, diabetes, diabetic retinopathy, vein occlusions. In glaucoma, there's more and more data emerging, and we're still kind of figuring that out, but we know that vessel density very likely has a role in these patients there. So, and then you look at trend analysis. You look at trend reports over time. The definition of glaucoma is a progressive optic neuropathy, and we have to watch this over time, progression over time, whether it's ganglion cells, OCT angiography, and the software can follow this over time and help us to identify, is there progression happening there. Again, lots of different ways that we can do this. And then don't forget the eye wellness and the angio wellness when you're running this on your patient and maybe they don't have significant pathology, but we want a quick wellness scan, whether it's eye wellness, the angio wellness. We've got OCT angiography, the retina, we've got ganglion cells in here just to pick up any early changes. Some of the earliest changes in glaucoma, ganglion cells. Some of the earliest changes in diabetic, maybe capillary dropouts. A little wellness scan to help us identify changes sooner. So, all right, that's your review on the posterior segment stuff. Again, most of that has been around for 1, 2, 3 years at this point with the Optovue Solix by Visionix. This is the exciting stuff now, the anterior segment stuff, new pachymetry, full range anterior stuff, and I'm going to pass it to the expert, Dr. Tackett.
Perfect. Yes, so I, like Dr. Lighthizer mentioned, had the honor of being able to be part of the R&R study. So I got to play around with a lot of this stuff quite often. We had several patients that we ran several scans on. And one of the really neat things that we discovered was added to the machines is the red-green crosshairs. And that is just to help us get a more consistent, high quality, high resolution scan. Whenever you are trying to scan your patient, it helps you with centration without having to look to the left at the image of the front surface of the eye and then back over to the right at the signal strength. You know that if you are aligned well within the green, you're probably going to get a better signal strength on that image. We work a lot with students in my setting. I know a lot of private practice docs work a lot with technicians, and it's just helpful to have something that can be used across the board and help us to get a more consistently good scan quality. We've had the corneal map scan, and historically this has had 2 maps on it instead of all 3, and now Visionix has added the 3rd map onto this display for us, which is really beneficial. Whenever we're looking for things like corneal ectasias, we want to be able to see the overall corneal thickness as well as the thickness of the stroma and the thickness of the epithelium to be able to correlate those all together and see how they play with each other. We know now in the literature that early ectasia shows epithelial remodeling, so being able to see that epithelium specifically in tandem with the pachymetry and the stromal thickness maps is really helpful whenever we're looking for things like ectatic disease. As Dr. Lighthizer mentioned, trend analyses are very important in a lot of things in eye care, and the front surface of the eye is not excluded in that. So this is a bilateral trend report that is new to the Solix device. We can run this report for several different scans. So you can run it for pachymetry, you can run it for stroma, you can run it for the epithelium, and it's very beneficial for following different conditions. Things like ectasia. We know that ectasia over time, if it is progressing, will show a thinning of the corneal surface. And as that thinning happens, that will show up then on this trend analysis. We also know that it is, although asymmetric, a bilateral disease. So being able to see the trend with both the right eye and the left eye on the same screen helps us to compare efficiently there. You can also see the stromal trend analysis. This could be beneficial in ectasia again, or even monitoring pre-refractive surgery to post-refractive surgery, seeing the change of the stromal thickness over time. And then, like we said, the epithelium is going to change in early ectasia as well. You're going to see that epithelial remodeling with thinning over the corneal apex and a circumferential thickening of the corneal epithelium. And that would be shown here on this trend analysis as well. The other thing I think this trend analysis would be really helpful for with the epithelium is looking at things like orthokeratology fits, trying to see where is that tissue moving and are we getting the effect that we want with the treatment that we have implemented there. Did I go the right way? Let's see, there we go. All right, so I mentioned earlier that this is my probably most run scan out of every scan on this machine, just because I do a lot of scleral lens fittings. I have been in the laser clinic a little bit as well, trying to look at the angle before and after a LPI. And one of the most cool things to me is that this scan, whenever you take it, will now have automatic placement of several different calipers. Whenever that automatic placement happens, you're going to be prompted to confirm the measurement values. You can either accept those, you can edit them or delete them. And I think it's really beneficial for a lot of us in the clinical setting because we're trying to be very efficient. This gives you one extra tool in your toolbox, one less thing that you have to go in and manually put on the scans, because the Solix is now going to be doing that for you, and all you have to do is check them to verify they are accurate. If you're looking for a white to white or a pupil size, you can manually add those on as well, which can definitely be beneficial in different contact lens fittings. But as far as your cross section of the anterior chamber, this will auto-populate for you, which will be very, very beneficial and help improve efficiency in your clinical care.
And Dr. Tackett, I was just going to comment, if you go back that slide, to me, this is just such a huge thing because, I do a lot of lasers and, narrow angles and things like that. And, I was never a huge fan of the OCT and the calipers because when you manually place it, you can make the angle look as wide open as you want or as narrow as you want, depending on where you put the caliper. So to have some guidance and have that to automatically put in there to help eliminate at least some of the subjectivity, to me, is very, very nice. Let it automatically place it before a PI, after a PI, and to show the improvement. I think that's very cool to have.
Definitely. Yeah, added consistency for sure.
Yep.
So this is kind of my bread and butter. What I absolutely love is ectatic disease. So whenever we start looking into some of these cases, we're going to look at the corneal map and see how that appears with an ectatic cornea. And then we'll kind of get into what we're really here to talk about today, and that's the topography modules and how that will appear with different conditions. So first off, just looking at what already is on your Solix device with the software update is the corneal map scan. And so, like we said, we have the pachymetry map, the stroma map, and then the epithelial map. And I mentioned how it's really important that we look at the thickness values across all of these metrics at the same time to see how they compare with each other. So we have in this very great example that classic inferiotemporal thinning of the cornea that you can see in the overall pachymetry map. That then is seen in the stromal map as well, with stromal thinning there in the same area. And then we mentioned that the epithelium is going to start to remodel in early ectatic disease. You'll see that thinning over what we presume to be the corneal apex and the inferiotemporal aspect of this cornea, with that circumferential thickening of the corneal epithelium that you can see there as well. One thing that Solix has also had added to it is the highlight tool that you can see, that little checkbox that they marked right here, if my mouse is showing up there. And that just helps to change the scale and make that epithelial difference pop out a lot more apparently to the eye whenever you're looking at the scans and just visually looking for the color change on the map. So talking about ectatic disease, that leads us to our topography module, which is really what we're here tonight to talk about and what we're really excited to reveal to you guys. And I think before we really get deep into the topography module, I think it's really important for us to talk about tomography versus topography. And Visionix very strategically named this a topography module because that really is the term that most of us use in our clinical day-to-day lives. But whenever we really start looking at this device and what information it gives us, it really is more of a tomographer. And that's really important for us to understand the value of this module, because not only are we getting the anterior surface information, the anterior elevation, the anterior axial map, but we're also getting information about the posterior surface, which we know is very, very important in detecting early ectatic disease. Now that we have treatment options like the advent of cross-linking, it's super important that we are finding these ectasias very early on in the disease process so we can work to slow the progression of the disease before the patient experiences worsening of their day-to-day life and their activities of daily living related to their condition. So the other thing that's beneficial with a tomographer versus a topographer is that it is tear film independent. A lot of us have the topography machines that we rely on mostly in our clinical space, which is very tear film dependent because it relies on that placido disc image reflected back at the machine. Whenever you're using an OCT to develop these maps and to gather the data, you do not need to worry about your tear film, which is often very disrupted in the case of ectatic disease. So it takes one factor out of the scan acquisition and helps you to get a better scan more consistently. So as you can see, there are several scans available for your interpretation, and this is the main report, the first report that will pop up whenever you click into the topography module on your Solix device. And this report specifically, you can change all of these maps independently. So you can really set this up to have whatever maps you prefer to look at whenever you're looking for ectatic disease, whenever you're looking for if someone is a candidate for cross-linking, or if someone is a candidate for refractive surgery. You can decide what maps you feel are most beneficial to you in your clinical decision making. So as you can see, this is a really great example of an ectasia, an ectatic cornea. We have on the left-hand side our axial maps of both the anterior surface and the posterior surface there on the bottom. And we talked about how you're going to see that steepening and that elevation on the posterior surface first, which you can see there as well. In the center, we have the pachymetry on the top, where we see that thinning that is characteristic of ectasia. We know that ectasia is not by definition a steepening of the cornea, but rather a thinning of the cornea. In that middle bottom map, we have that epithelial map that we talked about. We'll have that thinning and thickening. And then in the right-hand side, you have your elevation maps. And like we said, the posterior surface is going to show that elevation change before the anterior surface. So it is very, very important that we have a device that is able to give us information about the posterior surface of the cornea and not just being solely reliant on an anterior surface map. This is another report that will populate if you ask it to. It's called the refractive map. And this one is set. You cannot change these maps, and that is intentional to prevent any error in the operating room if you were to use this in the OR. It is set for you to know exactly what you're looking at in what position on the page. That way there's no error based on a map getting changed without your knowledge. This is another report. You can have it populate, and it's just the crystalline lens report. And the difference here is that you have the cross section of the anterior chamber in the bottom right-hand corner. All of the other maps and squares are editable. You can change those to be what you would prefer to see if you populate this report. And you can change that in your user preferences. All right, there we go. This is basically like we talked about, where you're going from one eye in all of those last reports to a bilateral report. We talked about how ectasia, while it is asymmetric, is bilateral, and it's really important to assess both eyes together to see how they compare with each other. Maybe one eye looks completely normal, but the other eye has ectatic disease that we need to be able to detect. This is a really good way to do that. It also gives you more metrics there in the center of each eye, telling you the location of the pupillary center, the location of the thinnest point on the cornea, the K max, things of that nature that are really beneficial whenever we are looking at diagnosing ectatic disease and trying to set a baseline for our patients moving forward. There we go. This is a comparison map, so I think that this would be really beneficial in things like refractive surgery, pre and post, things like orthokeratology, pre and post. It will populate a difference map for you there on the right-hand side, and that will show you the exact difference in power or whatever else you want it to populate, epithelial change maybe, or stromal change, and that is beneficial for monitoring these patients pre and post these treatments, and will give you a good idea of, is your treatment working? Did you hit the mark that you were hoping to hit? And what your result was after the treatment was initiated. Back to a trend analysis here, we can see the single eye trend analysis, and you can have two different options or two different maps, to monitor over time. So we can look at the baseline, and then as they progress over time, is the corneal thickness changing? Are we having progression in our ectatic disease? Are they a candidate for cross-linking? And I think that's where this is most applicable and most useful to us in our clinical care. Not only can we do a single eye trend analysis, but we can do the bilateral trend analysis as well. And like I said, you can monitor two different metrics at the same time. You can also use that highlight tool for the epithelial power the epithelial thickness, to really let those colors draw your eye to the changes and to the abnormalities. And then, like we said, elevation is very important, especially on the posterior surface of the cornea. That's where we're going to see change most early on in the disease process with corneal ectasias, keratoconus and pellucid, even post-refractive ectasia. And so when we look at the posterior elevation maps, we know that there is a point where we are no longer considered to be in our normal ranges. Just like we talked about with the posterior segment things, there is a point where we're not in that is 5% to 95%, and that is where we start to be concerned and want to look a little bit closer. And with this map, that posterior elevation maximum for non-diseased eyes is about 28 microns over the best fit sphere. So it's important for us to be paying attention to those numbers and looking to see, do we feel like that is rising above that point? Do we feel like we need to look closer for any kind of ectatic disease in this case? This device also has the ability to show you the aberrations that a patient has in their eye. I think this is really useful for patient education. You can toggle between what their eye sees versus full correction, and that's really helpful to show a patient, this is what you see and this is what we can do to try to make it better. And using this for patient education, I think is really beneficial whenever you're talking about maybe refractive surgery, maybe using scleral lenses, things of that nature, to really get that patient buy-in that you need before you go into such an extreme either scleral lens fitting process or going into a refractive procedure or anything like that. Dr. Nate, anything that you would like to add on this?
No, I just think, you know, the ability to have this available to talk to a patient, really education for the doctor, knowledge for the doctor, and to be able to show this to a patient, you know, and to help them understand, well, you're seeing well on this chart, but okay, this is why you're not seeing as well as you think you should be seeing, you know, even despite the numbers on Snellen or other things saying you're pretty well. So I just think this is just another feather in the cap of this Solix device, of all of the different things that it can do.
Yeah. All right, the last thing here that we wanted to kind of talk with you guys about tonight is just a few images from the R&R study that we collected for the anterior segment portion. This is an example of a post-refractive topography here. You can see on the Solix device, you can see that kind of flattening of the central cornea, steepening of the peripheral cornea, the epithelial remodeling just a little bit there as well. And then the anterior elevation is much less than the posterior elevation, just because we have kind of shaved down that stromal thickness to give the patient the power correction that we desired in this case. The other case I loaded up for us is a keratoconic case. We've talked a lot about this tonight already, but just to reiterate, we're looking here at the anterior axial map to see that there is that inferior steepening happening here. The posterior axial map also has that inferior steepening. When we look to the central column, we see that epithelial remodeling that we have mentioned several times before tonight, with the thinning happening right near that corneal apex and that thickening happening right around that point as well. Then we look at the power of the cornea. And then over on the right-hand side are elevation maps. These are some of my favorite maps to look at for ectatic corneas, to see where is that elevation and what does the posterior surface look like compared to the anterior surface. Is there a large difference there? And is the posterior elevation much more significant than the anterior elevation? Those are all things that we take into account. The other thing to look at is the peak of the cornea in the same area as the thinnest point of the cornea. And honestly, if I were to populate this myself, I think I probably, instead of true net power there in the bottom middle column, I would probably put the pachymetry map there to see, is the thinnest point of the cornea in the same location as the steepest point? And that will help me to decide, is this truly an ectatic cornea? I don't think any of us would have an argument here to argue that this was not an ectatic or diseased cornea, but it's a great example just to see how well this topography, dare I say tomography module, it will show these conditions and how valuable that information is to have the posterior surface as well as the epithelium and the anterior surface as well.
Well, and Aubrey, wouldn't you say that, you know, it's pretty much it's standard of care at this point to get these types of scans in any refractive surgery candidate? And
absolutely,
really we need to have this data for a lot of our contact lens patients as well, whether they're sclerals or other, to have proper fits and understand what's going on. So, I mean, so having this data and being able to manipulate this, as you said, you would change that true net power to a pachymetry map just to give you more insight on exactly what's going on.
Well, and now that we have corneal cross-linking as well, I think that that even gives us more reason to need to be able to see the posterior surface of the cornea, to really catch those ectasias earlier on in the disease process before they're affecting the anterior surface. So,
yep, absolutely.
This is the last case I wanted to share with you guys, and this is one of my favorite things about the Solix. We mentioned that full range anterior chamber scan. And one thing that Visionix has added to the Solix device is the radial anterior chamber full range scan. And this is so beneficial. Beforehand, before this was on our device, I was taking 4 scans per eye on my scleral lens fits. Now I hold the lids and I press the button once, and it gets me all the information I need on my scleral lens fits. I can see the landing zones, I can see the limbus, I can see the central clearance, and I can see that not only in one slice, but in 8 slices around the eye. So just like we talked about before with the posterior segment things, you're less likely to miss things the more data you have. Same thing here, you're less likely to miss an area of touch, you're less likely to miss an area of edge lift that's bothersome to the patient if you have more scans. And the fact that you can capture all of these scans in one click really is so beneficial in your scleral lens fittings as you are trying to master the fit and really get the patient the best vision and the best comfort that you can out of that lens. This is something that my students have loved. The resident this year has really loved getting to use this because it really does make you so much more efficient as you're comparing your OCT scans to your slit lamp exam to really fine tune that scleral lens fit. So just something I wanted to share. We hadn't hit on it yet, and hopefully that's beneficial for you guys as well.
Awesome, Dr. Tackett. That was just great. We're going to open up for questions here in just a second, but just to sum up, you know, you guys, I'm sure know the Optovue Solix by Visionix and OCT and OCT angiography, whether it's the nerve, the retina, taking fundus photos, but everything that Aubrey covered tonight, from fitting scleral lenses to earlier diagnosis of ectatic disease, dry eye management, everything involved with this anterior segment module, the topography and really tomography, as she so beautifully outlined. You now have all of this in one device. You got a mybographer for dry eye management. So Visionix has just done a tremendous job of putting all of your tools that you would want into one device from front of the eye to back of the eye, and just commend them for this amazing device. And let's now open it up to any questions. All
right. And thank you to Nate and Aubrey for that. Let me pull up the question screen here. So on your screen right now, this is the time. Feel free to ask some questions, and Aubrey and Nate are both here, and they can answer your questions here in real time. So can you hear
me, Adam? Good evening, everybody.
Yes. How's it going?
Good. How you doing?
Excellent. So great presentation, and the questions are rolling on in. So let me answer, or I'll ask them in the order in which they came in, right? I'll be really fair about this. So first question, is this being recorded? The answer is yes. So because someone has staff that they want to view this video, yes, this will be available on ODwire, and you guys will all get an email when it's ready to be viewed, when the archive is up on the site. And question here, a person set up on the screen during the video, they saw a label that said antaxial. So does this have any measurements for axial length to use for myopia management?
No, so this, the anterior axial was referring to the axial topography map. So rather than being like a tangential map, it's an axial map, just meaning like the way that it's measuring the steepness of the cornea and the way that it's populating the map. So not related to axial length there, just the kind of a topography image that it's showing.
And follow-up question here, this person's trainer who trained them on the device didn't know the answer for this one, but maybe you guys will. Is there any way to take measurements from the radial AC scan for scleral lenses?
The radial AC scan, so like the full range radial AC scan, maybe. I use that often, like the last case that I had mentioned, for scleral lenses. And yeah, I just have the scleral lens on the eye, and I'll have the patient look down, hold the upper lid, and then I'll actually have the patient come around and pull down their lower lid for me. That way my other hand is free to man the joystick. And then once I get it centered between the two lines, I'll have the scleral kind of maxing out at the top line on the capture screen. And I wish I had a picture of what the capture screen looks like, but I don't. And then I'll just, once that scleral, top of the scleral, I should say, I guess, anterior surface of the scleral hits that top line, I go ahead and capture. And it takes it really, really fast, all of those B scans. So,
question here, is a map of scleral lens clearance over the cornea either available or forthcoming?
A map of scleral lens clearance. So I'm interpreting that to mean like it would auto-populate the clearance in all of the different areas. And to my knowledge, that doesn't exist. But you can go into that radial full range AC scan and manually put in your clearance measurements wherever you feel like you want them. And you can do that on all 8 B scans that it takes. And then you can pick, which ones you want to display on the screen. You can do up to 4. You can do as little as 1, I believe. And you can also view them all individually. So you can manually kind of create that, I suppose. But to my knowledge, something that auto-populates along those lines doesn't exist.
Right.
Yet. I'm not sure if it's in the works. I would imagine that would be pretty technical to figure out, but.
Sure. And in fact, this person had a follow-up question. Is the corneal topography tomography mapping capability truly a replacement for a Scheimpflug tomographer?
I don't know that Solix is necessarily trying to replace, but I think if this is giving you that posterior surface and the pachymetry information that you need, and you feel confident in managing your keratoconic or ectatic patients with this, you're getting the information that I believe is standard of care. So I feel like, you would be validated to do that.
Right.
100%.
Dr. Lighthizer, any?
100% agree with that answer. Yes.
And a question here, will Solix give anterior chamber depth?
So that, I believe, would be part of the auto-populating calipers that are placed on the full range AC scan, as long as you're centered, I suppose.
Question here about setup and training. Actually, this would have been my first question. Seeing all the functionality of the device, what is the training steps, that one goes through when one actually gets a Solix installed? I guess the very first question we had was a person who's, getting set up with the new module. But in general, what's the process look like when you're getting onboarded with a Solix?
I think this is another question that's probably directed towards the Visionix folks. I mean, both Dr. Tackett and myself are in a unique situation of we were trained on this device as we were going through the FDA trials, whether it was the posterior segment stuff, the repeatability and reproducibility study, the normative database study, or again, what Dr. Tackett just went through this summer with all of the anterior segment stuff. So our situation is a little bit unique in terms of it wasn't buying a brand new instrument once it's post FDA approval. It was going through all of that. So I would kick that one to the Visionix folks, going, what's the typical training and implementation process that they prefer to implement?
Yes, so when you purchase the device, our clinical application specialist team will go out and install it. They'll also that day train your staff. So, we always encourage you to have, as much staff there as possible that day. And they'll go through and they'll walk through the different reports with them and exams and how to do the acquisition. And then we will give them the information to be able to log onto the academy. And every single person at your practice can log into the academy, and they'll be able to look at all the different acquisition videos on how to take any of the scans. And then we also have some videos that are on there from doctors as far as interpreting, and videos like this, previous webinars, so you can learn more as well.
Got it. So the academy is like a portal that people log into?
Yeah, it's like an online portal, and for all of our devices, it's also where you can get your manual from if you need it. as well.
And question here, which I'm fairly sure I will not get an answer to directly right now. So, but Sarah, since I have you here, someone wants to know about pricing and how is it actually priced? They were talking about the individual module here tonight, but in general, what does pricing look like for the Solix? How does that work?
Yes, so for the Solix, everything is usually included with a full Solix that you see, except for the topography module. The topography module is an additional upgrade. Right now we have some great introductory pricing on it since it just came out. So something you're interested in, if you go to that visionix.com/US/ODwire and fill out a form there, one of our team members will get you in touch with your sales consultant and they will talk to you about the options and how much pricing is currently, and especially with our end of year specials. So.
Excellent. So I got a comment here from someone who owns a device but does not know about the Academy. What's the easiest way for this person to actually get set up with an account in the Academy and to log in to look at the videos?
Yes, so if you go to the website, on the top of our website, there is a link to the Academy, and then you register with the Academy with your customer number, which is on your invoice. And if you do not know that, you can reach out either directly to your sales rep if you know who that is, or again, just you can go on our website or the Academy itself and just fill out a form, and we will get you your customer number to sign up.
Great. And if you're totally befuddled, remember, you can always email me after this because I'll be shooting you guys emails. And if you really need help figuring things out, I'm always around too. So feel free just to fire it off to me. Just respond to the email that you'll get from the webinar. So happy to help out. Here's an interesting one. Does Solix give a risk score or any analysis for keratoconus?
I'm not aware of any risk score where it gives you like a number for the keratoconus. Dr. Tackett, are you?
No. One thing that the Solix does have, though, that like Scheimpflug imaging does not have is that epithelial map. So it doesn't give you a risk score or anything like that, but you do actually get a little bit more data than you would a Scheimpflug image. So a little bit of a trade-off there.
Okay, so I think we're just about out of time here, but if there are more questions, about the device or anything at all, this webinar will be archived up on ODwire. There'll be a discussion thread running beneath it as well. Feel free to ask questions there. Or again, as I mentioned before, if you have any questions and you just need to reach out, respond to the emails that the system will be sending you, and those will go straight to me and I could forward them to the right person to answer your questions. So again, thanks again, Nate and Aubrey, for showing up and doing this tonight. It was actually chock full of information, and I hope everyone, really got a good look at the device. So again, thanks everyone for showing up tonight, and I guess I'll see everyone online.
Thanks, everybody. Have a great evening. Hope you enjoyed it. And again, come in. Thanks to Adam for putting this on, and Visionix for having a product like the Solix that just does so many things and has so many tools in our toolbox, all in one instrument. Just a phenomenal device. And a special thanks to Dr. Aubrey Tackett. Isn't she amazing? Awesome. Pick her brain. She is just a true expert with this device, especially in the anterior segment. So it was a pleasure to share the stage with her.
Yeah, thanks for having me. It's nice to be here.
All right. Thanks so much, guys. And have a great evening, and I'll see everybody online.